Whatever the air which is remaining in the first 16 generation, that is what is called as the dead space, because that air will not be useful for the exchange of the gases. So this can be asked as a multiple choice question, that how many generations of divisions are there? 23 generations. Out of that, first 16 generations are the one which can be considered as the dead space air. What do you mean by dead space air? The air which is not utilized for the exchange of gases, or the air which is not useful to the body, from the air from which the oxygen cannot be taken in and the carbon dioxide cannot be evolved into that, right? So this is about the dead space. When we speak about the dead space, whatever I have told you about the first 16 generation, that characteristically that is mainly the anatomical dead space. Why it is anatomical dead space? Because it is about the histological or anatomical peculiarity of the respiratory passage, by which the oxygen cannot be absorbed through it, right? So it is because that is called as the anatomical dead space. But there is also one more which is called as the physiological dead space. Now what do you mean by physiological dead space? First you have to understand what do you mean by dead space. The air which cannot be utilized for the exchange of the gases. Now let's say this is suppose the alveoli. Alveoli is surrounded by what? It is surrounded by capillaries. Generally we call it as the alveoli. It is sitting in the net basket of the capillaries. That means so many capillaries will be there, and what will lie in the capillaries? The blood. What that blood is waiting for? It's waiting for the oxygen. Oxygen from the alveoli that will be absorbed into that blood. Carbon dioxide will be given out into this air. Now, if there is a condition that there is more amount of air in the alveoli, and to capture all the oxygen in that, there is a less blood supply. Normally there should be in a proportion. We will call it as V by Q ratio, that is ventilation to the perfusion ratio. It should be in proportion to 0.8%, that is the ideal ratio of that. But if the ventilation is more, air is more, and the perfusion is less, that means if the blood supply is less, now what will happen? Some amount of oxygen or some amount of air, again it is not being used up for the exchange of the gases. So in that case what will happen now? This is called as the physiological dead space. So what do you mean by anatomical dead space? Because of the anatomical peculiarity, that air is not being used up for the exchange of the gases. That is anatomical dead space. What is physiological dead space? Physiological dead space is because of the imbalance in V by Q ratio. Mainly the V by Q ratio has increased. So in that case, the physiological dead space will be created. In the normal adult human being, we will say that the physiological dead space does not, that means it is not there. That means it is ideal ventilation perfusion ratio is there. So the anatomical dead space will be equal to that of the physiological, that is equal to that of the physiological dead space, or we will say that it is 150 milliliters. So how much is the dead space? It is 150 milliliters. And what normally exists only is the anatomical dead space. Physiological dead space is not there. But physiological dead space can occur, or it can be generated if there is an increase in ventilation perfusion ratio. The question is that how we have calculated the anatomical dead space. That is equal to the 150 ml per this. That's how we have calculated. The calculation is done by the nitrogen washout method. Now what is this nitrogen washout method? Whatever the air you are inspiring, that consists of nitrogen, oxygen, carbon dioxide. Now what we do is that we ask the person to inhale the air. Now you have to remember the exchange of the gases. What I told you, exchange of the gases will occur at two places. One is between the alveolar air and the capillaries. The exchange of the gases will also take place. Not only that, but suppose this is the position at the end of the expiration. Now what has happened at the end of expiration? This was the passage and then some air was filled in that. Now the person inspires. What will happen when the person inspires? Now whatever the air was there inside the passage at the end of the previous expiration, I will call it as the old air. So what will happen whenever the person inspires? This alveoli, what will happen? This alveoli will just enlarge. Because of that enlargement of the alveoli, what will be created? Negativity. That is, negative pressure is created. Subatmospheric pressure is created here. And this will cause the sucking action. This is the basis of that. sucking action that will be there, and what will happen because of that? The air from the atmosphere that will be sucked inside. But first, which air will enter in the alveoli, this enlarged alveoli? The old air. That means the air which was there at the end of the previous expiration. So the old air will enter first. Let's say that this is the old air that is there. And now, which air will sit upon it? I am using the term sit upon it. That means which air will sit upon it? The fresh air. Now, there are certain differences between the old air and even the fresh air. That means in the fresh air, the oxygen content will be more. In the old air, the oxygen content will be less. So the exchange is also taking place at this point. The junction of that is the old air and the fresh air. So what you see mainly is that whenever the exchange of the gases is taking place, the exchange of the gases is also taking place between the alveolar area and the surrounding capillaries. So that is one side, and the another side is between the old air and the new air. This you have to remember. So what will happen? Now, if you understood this much, we can understand what is a nitrogen washout method. Nitrogen washout method, by this method we calculate the dead space. Now how we do this calculation? We ask the person to expire. At the end of the normal expiration, we ask the person to forcefully inspire just pure oxygen. What we ask the person to do? We inspire forcefully the pure oxygen. What will happen? The old air which was containing some nitrogen, which will go inside the alveoli, and on that what will be sitting? The fresh air which contains the oxygen. Right? Now the exchange of the gases will start. The nitrogen content, since there is no nitrogen exchange here, the nitrogen content will remain here as that of the maximum, but there will be some exchange of the gases here also, so that some nitrogen content in the fresh air here, that will also increase, but there will be just pure oxygen sitting here, mainly at this place. Now what I asked the patient to do now? To expire after he has inhaled the pure oxygen. Now deep inhalation of the pure oxygen. What I ask the person to do? Forcefully expire the air in a nitrogen meter, which is going to measure the nitrogen concentration. So I ask the person to expire forcefully. Now if you analyze again this picture, whenever the person will expire forcefully, what he will expire? First he will expire the fresh air. That means the one which is just containing only the oxygen. So what you will see? Will you find any nitrogen at this time in the expired air? No. Only it will contain pure oxygen. So that the person has started expiring, we will plot a graph now. On the y-axis, this is the amount of nitrogen. This is the time scale. So the person has started expiring, and by the nitrogen meter will calculate the amount of nitrogen that has been expired. So initially what you will see that the air which has expired here, what you will see that this only contains oxygen, no nitrogen. So you will not record any nitrogen here. So what you will see that only oxygen is there, no nitrogen. Now what will happen? Slowly you will get this air where the exchange has taken place, where the diffusion has started. And now what you will find that the nitrogen content of the air will slowly go on increasing. Now whenever the person continues more and more expiration, what will happen now? This alveolar air will start getting expired with the forceful expiration, and now the nitrogen content of this air will be reaching to the maximum. So if you analyze this now picture, what you will see is that if you look at this graph now, the nitrogen has reached to this maximum. So what is my dead space? This is the air which has not been used up for the exchange of the gases. So if I plot this area, if I calculate this area, I can know how much is the dead space. So by this nitrogen washout method, I can know exactly how much is the dead space. I just want to know this amount of the area, and by that the marked with the cross. So that is equal to what will be called as the dead space, right? Now we will see about the physiological anatomy of the respiratory system. What you see is that we have got the rib cage, and inside this rib cage we have got the two elastic balloons. This rib cage is a closed cavity. This is a closed cavity, as you can see here. The only opening is mainly to the trachea, right? The bottom of it is closed by the dome of the diaphragm. And what are these lungs? These lungs are the two floating balloons. I am calling it as a floating balloons inside this closed rib cage cavity. So what you have to remember, the rib cage cavity is a closed one. Only connection it has got is with the through trachea, and where that trachea the trachea will mainly end in the two elastic balloons which are floating inside the rib cage. Why I am calling it as floating? Because the connection is only at the mediastinum to the trachea, as elsewhere the connection will not be there. They are the inflated balloons that will be there, and the space between this will be called we'll call it as the visceral pleura, the outer layer of the lung here, and this will be calling as the parietal pleura, the inner layer of the rib cage. So the space between that will be called as the pleural space. This pleural space is very, very important. This pleural space normally is negative. Negative means what it will have? It will have the suction effect. If this is negative, what will happen? It will keep the parietal pleura and visceral pleura glued to each other or attached to each other. Though there is no any fibrous connection between the parietal pleura and the visceral pleura, but they are glued to each other because of the negative pleural pressure. Normally the pleural pressure, we can say that the pressure between the pleural cavity is minus 5 centimeters of water at the end of expiration. It can again become more negative when we do forceful inspiration. So at the end of inspiration, it can reach to maximally it can reach to minus 7.5 centimeters of water. So this negative pressure is very, very important to keep the visceral pleura and the parietal pleura glued to each other. And if you try to separate it, what will happen? That the negativity again it will increase in the pleural cavity and it will try to resist the collapse of lung. What are the words? My words. It will prevent the collapse of the lungs. If it is trying to collapse, it is an elastic balloon. Lung, and because it is an elastic balloon, what will happen? It will try to constrict. It will try to collapse. But what prevents the collapse of these lungs is the negative intrapleural pressure. To analyze it, if you take two glass slides and if you wet it with water, wet them and then stick to each other, what will happen? They will get stick to each other. If you try to separate, you will not be able to separate. But at the same time, you will be able to move these two slides over each other. So two wet slides, if we keep over each other, we are not able to separate, but we are able to move over each other. The same way is the function of the lungs there. The lungs can move into the pleural, that is into the rib cage, but they are glued to the parietal pleura in the same way. Now the question is that, who keeps this pressure negative? You understand the importance of this negative pressure now. But the question is, who keeps this pressure negative? It is the potent lymphatic system. The potent lymphatic system, it will cause continuous suction of the fluid. It will make sure that no fluid gets accumulated here and it will keep the pressure in the pleural cavity negative. And what is the importance of that? It will prevent the collapse of the lung and at the same time it will cause this. Now with this anatomical background, now if you understood, we can actually go for the process of ventilation. So what do you mean by ventilation? What is the definition of ventilation? It is the process by which air can be taken in from the atmosphere and take into the lungs, and again from the lungs it can be expired out into the atmosphere. This process is called as what? Ventilation. What causes ventilation? For that, as I have told you earlier, it is the negativity that is generated. The alveoli will expand. The respiratory system that is again going to expand. So what will happen because of that? The expansion will cause the subatmospheric pressure, and that subatmospheric pressure will cause suction of the air. Got it? Okay, so it's because of the suction. It is because of the negative pressure. It is not the positive pressure ventilation. There is no, it's because of the negative pressure that is being generated. Now question is that, what creates this negative pressure inside the alveoli? Or what causes that expansion of the alveoli? What causes the expansion of the respiratory passage and ultimately the negativity? It is because of the certain movements of the rib cage and the diaphragm which are there. Now if you analyze your ribs and the rib cage together, what I told you, the rib cage is a closed cavity. Now, look at what are the types of movements, how we inspire, the mechanics of inspiration. For that, you have to understand these are the ribs. Let's say what is how they are what the joints they have. They are joint at the vertebra at the behind and the sternum in the front. Now, if this is the, let's say, initial position of the ribs, slang they are slightly slanted. Now what if they move in this direction? Okay, like a handle of a bucket, like a handle of a bucket. So what will happen if both the ribs move like this? What will happen at the anteriorly at the junction between the sternum and the ribs, and at posteriorly between the vertebra and the ribs? What will happen if this type of movements take place? Lifting of the ribs. What will happen in this case now? The transverse diameter of the rib cage will increase. So bucket handle movement will increase the transverse diameter, right? Next, imagine now, this is the resting position of the ribs, right? So the anterior part is slightly slant downward. Now what will happen if there are certain muscles which will lift up the anterior portion of the ribs along with the sternum? So this much part is lifted up. What will happen now? Because of the lifting up of this, now what will happen? The anterior posterior diameter is going to be increased. This type of the movement is called as the pump handle movement, right? So you have got is the bucket handle movement, which is going to increase the transverse diameter, the pump handle movement, which is going to increase the anterior posterior diameter. And now look at the dome of the diaphragm. What is this is the dome of the diaphragm. If the diaphragm muscle constrict, what will happen now? Constriction of this diaphragm muscles, what it will do? This is the diaphragm which has constricted now. So what will happen because of that now? The vertical diameter it has increased. So bucket handle moment will increase the transverse diameter, pump handle moment will increase the anteroposterior diameter, and the constriction of the diaphragm will increase the vertical diameter. Rib cage is a closed cavity. So if the volume of the rib cage it has increased because of this, now what will happen? The pressure inside the rib cage will become negative. So that is the main cause of that. And this negative pressure will try to expand all the viscera present in the rib cage, including the alveoli, including the respiratory passage, even the heart chambers. They are slightly expanding because of this. So what has happened? The vessels also, they get expanded because of the negativity that is created, right? So this is the major cause of the inspiration. The expansion of the rib cage volume, the negative pressure that is created, the alveoli will get expand. Once the alveoli get expanded, the negative pressure, subatmospheric pressure will be generated, -1 centimeter, that is -1 centimeter of water in, and because of that what is going to happen? The atmospheric air that is being inspired, sucked in. So this is the major cause of this. What is the process of expiration then? What this has happened. Just the elastic recoil. The rib cage will come back to its original position now. Just the elastic recoil. So what will happen? What are the ribs? They will be lifted up. They will be slanting downwards. Even the anterior portion of the sternum, it will go down. Not only that, but the diaphragm which has contracted, it will just relax now. Now what has happened? There is a decrease in the transverse diameter, decrease in the anteroposterior diameter, decrease in the vertical diameter. And what will happen now? The pressure inside this closed rib cage cavity will slightly increase. Because of that, what will happen now? Since the alveoli are elastic one, they will just collapse. And now what will happen? Collapse of alveoli will cause pressure to become more positive, slightly more positive than that compared to that of the atmosphere. So because of that, what has happened now? Once that the alveolar pressure has become positive, the air will be forced out. So this is the process of expiration. Remember, the tidal expiration is mainly because of the elastic recoil. So that's the very important thing. Very less amount of the energy is used in the tidal expiration. But whenever the forceful expiration has to be done, forceful expiratory muscles that are being used. For tidal expiration, generally no muscle is required. It's just because of the elastic recoil of the rib cage and the total lung as such. But there are certain muscles which are required for the forceful expiration. We will see what are the muscles required for the inspiration, which will mainly lift up the ribs and which will going to cause inspiration, and which are the muscles useful for the forceful expiration. What are the muscles used for the tidal inspiration. Tidal means what? The normal amount of the air which we inspire or expire, 500 ml. That is the normal value. That is called as tidal volume or the tidal inspiration or tidal expiration. So what are the muscles for the tidal inspiration as such? Diaphragm. Most of the inspiration is mainly because of the just the diaphragm. Diaphragm will constrict, the vertical diameter will increase, and that itself is sufficient most of the time to cause the tidal inspiration. On and about that, the external intercostal muscles, they are also causing the lifting of the ribs and ultimately the bucket handle and the pump handle movement. So that's also used. For forceful inspiration, more than the tidal inspiration, there should be much more lifting of the sternum, much more lifting of the ribs. Now for forceful inspiration, we have got the sternocleidomastoid. That will lift up the sternum, the anterior part of the sternum, the ribs as such because of the sternocleidomastoid. Scalene muscles. These are the one again which are useful for the forceful inspiration. What are the muscles useful for the forceful expiration? The forceful expiration can be caused by internal intercostal muscle, and most important is the abdominal recti muscle. If you look at this straight muscles, what you see, if they contract, they are trying to pull down the sternum, the zipisternum, they will try to pull it downwards. Because of that, what will happen? The ribs will be pulled downwards, and they are very useful for the forceful expiration, right?